Right, so this should be live on YouTube. I know to everybody else this might be something you've done before. It's something I've seen and done, but this is my first attempt at actually trying to do it. So, um, thankfully, technology I think has been quite kind to me, and it is working. Um, so we'll see how we all get on. Um, Thanks very much for everybody that's here. A bit different to Zoom because I can't see how many people are logged in. I think that's quite a good thing because it just takes a little bit of pressure off. Worst case, if nobody actually sees this and it didn't work, then it's going to be saved on YouTube and you can watch it back at another time. So with the Spire, we did one of these before, very similar but different topics from pediatrics and from the adult side of things. And we got lots of feedback from both physios and GPs that the pediatric aspects of knee surgery are something that you wanted me to focus on. Thanks very much for some of the questions that people emailed. I've tried to incorporate them in to this, and hopefully I managed to answer the questions that you guys want answered. So for those that didn't attend the last one or have no idea who I am, I'm Mark Frame. I'm one of the orthopaedic consultants in Southampton in the general. I also work in the Spire and the Wessex Nuffield, but clearly from my accent, I'm not a South Coaster. I originally trained up in Scotland. I'm from Glasgow, but went to university up in Aberdeen, tried to get further away to the north of the country, and then did the absolute opposite and came down to the south coast and did a knee fellowship in Southampton with Professor Barrett, who I'm sure most people have heard of, as well as Professor Chapman-Sheath. After Southampton, did a bit of a tour all over the place and knee fellowship in Lyon with David Dejour, who's a patellofemoral expert, as well as Professor Adam Starr in Dallas in Texas, in Parkland Hospital, made famous by the Parkland formula for burns, which most people will have heard of, as well as where JFK went once he was shot, which is obviously dreadful. That was incredible. That was a trauma fellowship, and I'm now, as well as a knee surgeon, part of the major trauma team in Southampton General. My practice is pretty much pure elective knee. My trauma drifts a little bit further away from the knee, but anything elective and planned is very focused. So the plan tonight was really to distill things down to the important questions that you guys were asking. And ACL injuries, and particularly in the pediatric population, is something that's on the rise. So it's really worthy of spending quite a lot of time on. My second passion and the thing that I do a lot of and get tertiary referrals from the South Coast and across the country is for patellar instability. And we'll touch on that a little bit later. And if I can fathom the technology and can actually see some of the questions coming in on the YouTube chat, if anybody wants to put them on there, I'll try and answer some of them as well. At the moment, I daren't try and look at my phone or anything else to look at the chat stream, so I apologise if I'm ignoring anybody's questions at the moment, but we'll get to that later and I'll try my best. So a little bit of background, particularly with specifics of the pediatric ACL. It's amazing how many children now you really kind of categorize almost as athletes. Even my kids who are 6 and 8 at school are doing far more sporty things at a much higher level and a much higher intensity than we ever did at school. 50% of Paeds athletic injuries that require an operation and need something else done to them are knee related, and 25% of those things that have surgery within the knee are the ACL. So it's a really, really frequently injured ligament and part of the joint. Interestingly, and this isn't, I'm not sure whether this is to do with the number of injuries that are happening or whether it's to do with the confidence and the technology that's changed to allow people to do more ACL injury reconstructions, but the number of reconstructions happening in that pediatric population is on the rise, and the data obviously lags behind a little bit, but in 1997, there was 17 per 100,000, and then that's risen up to 50 per 100,000 in 2010, and it looked like it was on the rate of nearly 3% a year, so you can only imagine what it's at the moment. certainly from my experience, the number of children injuring themselves is definitely going up. The highest rate, as you would kind of expect, is the kind of adolescent child creeping towards adulthood, where they are starting to do much more risky activities and much higher energy sports such as rugby and football. And 17-year-old boys, that rate's nearly 450 per 100,000, and 16-year-old girls, because we all know that women and girls are much more mature than boys at every stage. My wife tells me that anyway. So taking it back right to the beginning, and I know that this is predominantly on the treatment, diagnosis, and what we do and rehab ACL injuries in children, but I thought it was a really interesting thing to touch on was that obviously prevention of these injuries is better than trying to fix them. As good as we are as surgeons, we can't recreate the normal ACL. So the things that we can change, and with any kind of disease that we look at trying to prevent, you want to look at the things that are modifiable. We can't change the non-modifiable, but we look at everything that we can modify. And the child's biomechanical mechanics and their movements and the way that they move themselves when they're doing the sports, we can change. And there's lots of injury prevention programs that exist now and are clear that they make a very significant difference to the rate of injury in athletes, and in particularly children. The International Olympic Committee and FIFA produced a program, and you may have heard of the 11 Plus for FIFA, which was really quite game-changing, excuse the pun, and managed to cut injuries in children and adolescents and young athletes by nearly 50%. We need to teach and educate the coaches and the people looking after these children and the parents of high-level athlete children and just kids that are playing sports at a high level, particularly with regards to the way that they move around on a pitch, the sort of cutting and twisting movements are the things that put your ACL at risk, and a wide stance when you do that, or landing on a flexed knee, or other players interacting or other children interacting with that person as they land and twisting onto their knee. So a lot of it's education, and a lot of work can be done with that to minimize the injuries to children. And it's an easy thing to implement. It doesn't involve equipment, it doesn't involve finance. It's really just getting that information out there. So I don't know if you noticed, if you've gone through this on the website, you'll have noticed just above the video, there's 3 PDFs that I've attached. So that's some documents that I've referred and taken some of this information from, and it's really, really quick read, but it's the IOC review of ACL injuries and prevention and diagnosis and treatment, as well as the FIFA 11 Plus and some other literature that I've looked out that might be useful to have a quick read through. So you can always browse back to the website anytime and download those PDFs. Non-operative was kind of the previous standard, and the reason that was really favoured in the paediatric population was because clearly children grow. That's the primary difference between an adult and a child when it comes to ACL injuries, and those growth plates and epiphyses round about your knee, distal femur, proximal tibia, are the most important in giving you length. So drilling holes and using screws and doing ligament reconstructions around the knee will have an impact on that, potentially causing growth disturbances or growth arrest. And that was always a big concern. So it was felt that doing nothing was probably better than potentially subjecting children to those problems. However, evidence now has shown that not doing an ACL reconstruction, leaving a child with an unstable knee, increases the risk of secondary injury within the joint. Your medial meniscus is a secondary stabilizer of rotation within your joint, and that will then have an impact. Give me 1 second. Will have a secondary impact on the articular cartilage, potentially causing chondral injuries and also damage to the meniscus, which long term will give children a problem with osteoarthritis. So doing an ACL reconstruction, giving that stability back within the joint is really very important. And those reconstructed sooner do much better than if it's later. The other very important thing is prehab, and that's with really optimizing the patient before they have their surgery. A lot of the physios will be very well aware of the importance of prehab, and I've got some criteria that I tend to try and stick to. The true prehab of trying to get the patient's quads back to normal hopefully shouldn't be a massive issue because we're trying to do these surgeries really quickly. But the ones that are really non-negotiable from my perspective are that they have to have no effusion by the time we're going to do surgery. And that's just indicating the level of trauma and ongoing inflammation within the knee. And we want that really settled before we operate. Thinking about 80% of the quad strength in comparison to their good knee, or really trying to get as close as that as possible. So a good measure is being able to do a straight leg raise and hold that for about 5 seconds. Also, the range of motion is very important. We don't want to then have a knee that's not quite fully moving, do a surgery on them that will then cause inflammation and problems and potentially restrict their movement more, giving them a stiff knee longer term. So I want to see that they have completely full extension and flexion up to 120 degrees before we'll go near them for an ACL reconstruction. I thought now it's good, now that we've given some background to this, to actually try and attach some real patients to the injuries and kind of go through the flow and my thought process as to what I do when these children come through. Similar to how we did with the last one, and close to my heart, we've got Alex, who's a 14-year-old, fit and healthy, really keen, going everything at 100 miles an hour. Ski race training, which down here is lots of kids, particularly at school. You see the children on the dry slopes, and race training has that very fast, dynamic twisting movements within their knees. And not uncommon, Alex managed to straddle one of the gates while competing, managed to get tangled in the mats. His ski didn't come off because when you're racing, you don't want your skis to pop off, and you tend to have your DIN settings much higher. And that twisting moment arm of the ski on the end of the foot just really compounding things, causing an injury to his knee. Complaining of immediate pain, absolutely no chance that he's going to be able to ski on, and was limping off the ski slope, really uncomfortable. His knee afterwards, immediately swollen, really couldn't manage the pain and ended up going to minor injuries. Given some crutches, x-rays, they told him, you know, there's a tiny flake of bone, don't worry about it, can't really see anything, you definitely don't have a big fracture. Here's some advice, giving you some ice, take some painkillers, and see how you get on. We've made an appointment to the fracture clinic. They'll see you in due course. So, you know, unfortunately, given the times we're in at the moment, and even before that, the fracture clinics were often very busy, and it's not just the general, but lots of hospitals often wouldn't see patients for 2 weeks, even longer. The swelling starts to settle over that time. He's a 14-year-old boy, he's desperate to get back to things, starts to feel better, forgets the issue. His range of motion is improving. Wants to start race training again, was playing football at school, and really not a major incident, just on the uneven ground. His knee gives way just running for the ball. Eventually brought back to the fracture clinic, seen it 3 weeks, and what happens next? So in a 14-year-old, it's slightly different than a younger child, in that they probably will be able to give a really good clinical history. You start to get into the younger population, they're not going to give you the classic textbook explanation of having had an ACL injury. We want to clinically examine them. You want to look, feel, and move. Those are the things that are in my brain. Orthopedics are really simple. Anything more than 3 and we start to struggle. Evidence, however, shows really quite poor correlation with clinical examination and injury. And that evidence and that data is from an expert population of orthopedic surgeons, but not even just orthopedic surgeons, but knee surgeons who do it all the time. And even then, it's clear that around about 80% of ACLs are diagnosed on a clinical examination, which is pretty good, but that still means that 20% aren't potentially. 50% of meniscal tears aren't diagnosed on clinical examination. And the number is even smaller for other injuries. So you want to do ligament tests. We've got Lachman's, difficult to do when the patient's acutely sore and swollen, really difficult to do if you don't do it all the time. It's probably the most sensitive in my hands. It's the one that I trust most. Anterior draw is the one that most people are taught because it is an easier concept and an easier examination to do. But once you bend the knee up, depending on how bent the knee is, it often will, you'll get secondary stabilization from other structures, and it can actually be quite confusing. And particularly if you've got a PCL injury, again, that all gets very confusing. So relevant if you know what you're doing, but like the data shows, it's not the way of really diagnosing anything. It's a useful adjunct if it's very obvious. Pivot shift, the one that confuses everybody, is something that I find difficult to do in clinic. I would imagine in a GP surgery or in a physio clinic after a week of somebody having had an ACL injury, it's going to be virtually impossible to do. It's the thing that I use most reliably in theatre. So, it takes the patient to be completely asleep, for their quads and their hamstrings to be relaxed, for that test to really work. And it's an uncomfortable, unpleasant thing that patients anticipate you're going to hurt them. So, if it's there, great. I wouldn't keep trying in a clinic scenario. It's not what we need to diagnose an ACL anyway. So my take home with that is really don't worry about special tests. Don't really worry too much about the clinical examination. I think the thing that I want to know from a clinical examination is their range of motion. A bit like my criteria before, you want to exclude to make sure that they clearly don't have a locked knee, which is obviously a really urgent, important thing to diagnose. Any significant knee injury, in my mind, it should be instantly referred. If somebody's had a significant amount of trauma and it's a big swollen knee, or they have an effusion, or they have what you think is a hemarthrosis, that's not something to sit on and see how it gets on. There's lots of different things that you won't be able to tell clinically or even from an x-ray as to what's going on that might need very urgent treatment. So, whichever pathway that you use to refer, depending on where you are and which hospital, try and really get that patient in as quickly as you can. If there's any concern and you feel that it's going to, the standard routes in are going to be too long, then a quick phone call to the on-call orthopedics, I think, is relevant, and let them make that decision as to whether they want to see the patient now. For those of you that are local to the general and in that referral area, I'm quite happy for somebody to send me an email. I've got my email here for the general, and also from a private perspective as well. I'm happy to answer anybody's emails. If you've got access to an MRI scan, absolutely. That's the gold standard imaging that we need to try and diagnose an ACL injury or meniscal injury or a ligament injury in their knee. That's absolutely the gold standard. Children, there is some evidence that MR is possibly not quite as accurate, but it's definitely getting much better, and it depends very much where you get that MRI scan. In the general, we have a very high resolution MRI scanner, so I would rather have an MR done in my own hospital rather than one done in the car park of Tesco's in a big van. It's not as relevant. I suppose the only other important aspect when we're talking about the pediatric population is if they're really young, then an MRI scan actually can be quite claustrophobic. It's not particularly pleasant. There's not somebody around with them, and any movement causes artifact, which, a bit like having a long shutter on a camera, you end up with blur, and it makes it very, very difficult to diagnose anything from that. So it's really important to discuss with the child and really prepare them for what an MRI is, just so that we can get the best possible images to allow us to diagnose everything. The other thing is to make sure that if you can't get an MRI scan and you feel that there's going to be a delay, an X-ray is still an important thing. Often it will show nothing because we're looking at bones, but if it does show something, then often that's when it's really important. So young ligaments are stronger than bone, and you often see what's called an avulsion fracture, which is instead of the ligament breaking, it pulls a chunk of bone off at the attachment, whether that's from the femoral side or the tibial side, and that's an emergency. That's something that's really time critical and needs fixed. So this slide here if you can see it, I know the image is probably quite small, but what it's showing is what looks like a flake of bone, and it goes back to Alex, who was seen in the minor injuries unit, and they kind of passed it over as just, oh, it's just a flake of bone, don't worry about it. Actually, that small flake of bone probably has a huge chunk of cartilage over the top of it that you can't see, which is really very significant, or it has their ACL attached to it. And if that's the case, that's something that needs surgical fixation. And the sooner you do that, the better. And we've said there's a nominal value of 3 weeks, but realistically, the sooner you get in there, the sooner the ACL is back to where it should be, and the sooner it can all start to heal back together. So realistically, I would see that the next day, but at 3 weeks, we can still probably do something, but it's not ideal. What we're trying to do in that scenario is, rather than reconstructing their ACL, is to preserve the ACL that they have and allow them to not require any further surgery in the future with a reconstruction. In the old days, that was fixed with a great big arthrotomy, which is a hole in the front of your knee, so that you can actually see what's going on. That chunk of bone is put down and great big screws put in, which often impinged and will often require to come back out again. Patients put into braces and plasters, which really has a massive impact. And from a physio perspective, you can imagine somebody being in plaster for 3, 6, 9 weeks. Their quads and their hamstrings afterwards are going to be decimated, and getting them back to full fitness is going to be a really long haul. So the surgery now, we fix them keyhole, and things are getting even more impressive. We can now do that with an arthroscope that's a normal keyhole arthroscopy kit is about 6 millimeters across. We now can use what's called a nanoscope, which is 2 millimeters, which has been incredibly helpful in the pediatric population. Obviously, a child's knee is much smaller, so all the space that we can get is fantastic. And using these incredible button tension fixation, so rather than screws, we're putting tiny little titanium buttons to squash that chunk of bone back down, to snug the ACL back to where it should be. And we'll often use what's called an internal brace, which is a nylon tape that follows the ACL and gives you primary stability of your knee. So that gives you the stability to be able to move and use your knee while this bony chunk heals, but without taking the force of the movements of your knee. A bit like putting a plate on a fractured bone. It holds things in position while your body heals, and just gives patients the best possible chance of that actually staying where it should do. It also allows early mobilization and allows us to rapidly get their quads back and working, and not lose any more quad bulk than we need to. This is just a picture of kind of outlining where the internal brace would go. So the blue line is the nylon tape following the ACL. The first one is an avulsion where the chunk of bone came off from the femoral attachment. The second one is a tibial spine avulsion, so pulling off from the tibia. And you can see that arthroscopic image there. The blue bit of string is the internal brace, and underneath that they've got the traumatized ACL. But it's been plumbed back into where it should be, and hopefully had an opportunity to heal without too much stress on it. So, Alex, we were talking about before, had this tibial spine avulsion that was fixed, like we mentioned on the last slide. If it's not an avulsion and there's no other pathology, the majority of kids who have been put in that position to have had an ACL injury because of the sporting activities that they're doing, a very high chance that they will go on to a longer term instability and require reconstruction. And going back to what we discussed at the beginning, the evidence is definitely pushing on that conservative management of a child, unless there's a very good reason not to take them to theatre and fix and give them an ACL that works normally, conservative measures are probably not the best with regards to ongoing injury to the knee. So an ACL reconstruction, maybe you may not have ever seen an ACL reconstruction or had patients with an ACL reconstruction. It's an arthroscopic procedure. It's day surgery. Even with the pediatric population, we tend to be a little bit kinder, and kids tend to stay over. But actually, when you get into that adolescent group, it's something that if they're done first thing in the morning, often they'll be desperate to go home in the evening, and there's no real reason to keep them as long as they're comfortable. Children tend to actually complain less, and if their pain is controlled and they're happy, they just want to get going. There's no brace unless you have a meniscal injury and we want to protect it. They're fully weight-bearing, full range of motion. We use hamstrings for reconstruction in the majority of children, and there's really no place for bone patellar bone in kids because we're still very conscious of the physis if it's open, and the last thing you want to put across a growth plate is a chunk of bone. And actually, if you've got soft tissue across a growth plate, that's less of a problem. It stops a bony spur forming across it. It prevents growth arrest. It prevents angulation. So in a way, having a soft tissue graft in that tunnel is protective. And as mentioned before, we've got these minimally invasive techniques now to do that using things like the nanoscope, and also the technique that I use, which is called the all-inside Arthrex. It involves 2 buttons, no screws. It doesn't use full tunnels. We only need one of your hamstrings as opposed to traditionally where you would take your semitendinosus and gracilis, so 2 hamstring muscles, and that has an impact on the pain that the patients have afterwards, the function of their hamstrings, their rehabilitation afterwards, and also the tunnels when we drill them in that way. If anybody does DIY and you've ever drilled a hole in a piece of wood, where you start the drill on one side, you've got a perfect hole, and the other side is all splinters. And actually, we want that perfect hole inside the knee. And this retro drill, where you're drilling from inside out, gives us those perfect tunnels, which just give the patients a much better graft long term. If they're really young, basically any children over the age of about 14, 15, when they've got very little growth left, going across their physis is generally not an issue. We still keep an eye on them for several years just to make sure that they don't have growth arrest or angulation of growth. But in the much younger population, as somebody was emailing about the kind of 12, 13-year-old group where they do have a significant growth left, then we need to be very, very aware of their physis. And this technique, because we can put the tunnels wherever we want, we can actually completely avoid the physis and do it all in the epiphysis. So it doesn't cross the physis at all. There's still an issue in that even if you're close to the physis and you don't go through the physis at all, the increased blood flow that you get for the healing that happens around about that can still cause, ironically, overgrowth. So it brings more oxygen, more blood flow to the physis at that area and can overgrowth. So no matter what we do, we still keep a very close eye on the kids over the course of the next few years of their growth until it stops, just to make sure that things aren't deviating off at an angle or causing a problem. So this is just some pictures. You can see the one on the very edge with the 2 screws and some wire kind of indicates some of the traditional techniques that people use, using screws in both tunnels or even just one of the tunnels. And if you compare that to my standard ACL reconstruction, where you have 2 very small little titanium buttons in short tunnels, and the middle graphic just is a clearer picture of what that looks like in reality. So the post-op goals. So one of the questions that was asked before we started this was to do with rehab. And generally, I am quite happy to relinquish that understanding, that control to the physios. But this patient population of a young ACL injury is one that there's not lots of patients. There's often not a nice regime. Kids are not just little adults that do well with the same rehab protocols that grown-ups will get. And I think one of the important differences is really that children and their muscles and the way that they rehabilitate or engage in that rehabilitation needs to be tailored very much to them. They can't just have a sheet of information or be given a certain number of exercises and shown a couple of times and be expected to be able to do that under their own steam. It takes a lot of input, a lot of discussion, a lot more time with them. But the main post-op goals that we're looking for really is very early passive and active range of motion. It's super important. We don't want anybody being very reluctant or scared to move their leg. I've seen kids who are almost terrified to move, even if it's not sore, and get into this cycle of fear, and then trying to get them out of that and get them moving is incredibly difficult. So very early passive range of motion, CPM if you need it, turn it into a game. Really good pain relief is absolutely key, whether it's kids or whether it's adults. There's a lot of people that, grown-ups, that really don't like taking painkillers and would rather sit in pain and do nothing than take some painkillers, and you really need to get past that. And in the pediatric population, some kids just don't want the taste of it. They don't want to take the medicine. And if they're very reluctant to do that, then they're not going to get going. They're not going to get moving and can end up with a stiff knee. Again, we all know that with your knee slightly flexed, that's when you've got the biggest volume within your knee. So when you've got swelling, you've got bleeding in the post-op stage, what you want to do is to sit with a pillow under your knee, have your knee slightly bent, and that's absolutely the devil position from an orthopedic perspective. We do not like pillows under knees. I'll go around a ward and take pillows out from underneath people and look like a really cruel guy. But the opposite is really necessary. So if you've got somebody who looks as if they're quite reluctant to keep their knee out straight, or they've got any problems like that, then putting a heel prop underneath the foot and actually just letting gravity do its work and let that knee come out straight is really important. There's no real strict aims at different stages. Everybody's very, very different. There's no real evidence on this, but as a guide, I kind of think I want to see that you're at 90 degrees comfortably by 4 weeks and 120 degrees by 8 weeks. Obviously, it depends on the degree of surgery that the patient's had, the other things that are going on within their knee, but that's a good rough aim. We also want to, overall, the main aims, as you guys know, is to restore strength and motion and confidence in that knee. So strengthening is really important, quads activation, and what they call neuromuscular training. And it's proprioception is the thing that long-term is going to prevent them having a further injury to their ACL and getting back to sport. And it's a difficult concept sometimes to explain to patients what we mean by proprioception, but it's that awareness of where your joint is, where the limits of your joint movement are. So really kind of trying to work with kids to explain what that means and working through balance, muscle endurance, making sure those muscles keep control for a long time. That's where, again, we see people having problems both in pediatric population and in the adult population of re-injury, is that they can do really well for a short period of time, and then as their muscles start to get lazy, that's when they start to put themselves at risk of a further injury. The way that we build strength back up and quads bulk is very different in the pediatric population. This is one thing that is a big difference. So the Hospital of Special Surgery in New York produced some evidence that showed that only about 80% of kids had about 85% of their strength and their quads bulk back at 2 and 6 months. It takes longer for kids to regain their quad strength than the adult population. And actually, as long as 15 months down the line, only 90% of them have, they're within 15% of the symmetry between their legs with regards to strength. So this is something that's a much longer term goal with kids, and it's really important to appreciate that in their rehab. It needs to be tailored to the patient's, the child's psychological and physiological maturity level. Clearly dealing with a 12-year-old is very different from dealing with a 17-year-old. As I mentioned before, giving them home-based programs or doing that rehab in their house, focusing on play and fun for the younger kids. Things that we do with adults, single leg hop, isokinetic strength tests are much less accurate in kids, and don't use that as a guide to getting them back to sport. It really doesn't translate. There isn't a huge amount of good evidence as to what does, but it's just being aware of the things that really don't. The decision of the return to sport is a difficult one, and I think patients always ask, I always get emails saying, when can I go back and play football? Can I go back at 9 months? I heard, I saw this footballer did it at 6 months. And I think there should be much less focus on numbers and time. And I think it's much more focused on, function and where they're at. If you've clearly got somebody who bounced back really, really quickly and they've got their quad strength back and they've got their proprioception and everything is working really incredibly well, they've got that stamina in their muscles, then clearly they're going to be able to go back to sport sooner than somebody who's 12 months down the line, who's still really struggling, who's got significant quads wasting, who's really not engaging in the rehab. So time is meaningless, and particularly with kids, I think it's assessing when they're ready, and it's going to be really sport specific. what you're aiming for with somebody who's a ski racer is clearly very different from somebody who's a footballer, who's a basketball player, who's playing tennis. So, this kind of one rehab program fits all really is not the case. So that's ACL. I'm scared to try and see if I can have a look on YouTube and see whether if you give me a quick second, let me have a look and see whether I can see what's going on with regards to the chat. I'll have a quick scout and see what questions anybody's asked, if there are any.
It's not the case.
So, give me 1 second. I think we're going to get into a feedback loop, which might cause us a problem. Oh, I think I'm in. Let me see. So, just looking through some of the questions, it says, with regards to referral, this is from Rob, from private physio practice into the NHS, would we have to go via the GP? If so, that's slow. Again, from the referral pathway, I think being able to directly refer, I'm not sure it really matters where that's coming from. I think if you contact the on-call orthopedic registrar, you don't need to have gone through a GP. It doesn't need a referral in that sense. If it's an acute injury that needs dealt with straight away, that's something that we'd be quite happy to accept. So no, it doesn't need to go through a bureaucratic process of going through the GP. I'm sure the GPs don't want to have to try and write a referral letter. That process would be very slow. So no, absolutely, Rob. If you just contact the on-call person directly or write a letter to the orthopedic department directly, it would be absolutely fine. Joe Pont mentioned that you're talking about growth plate issues when putting screws and buttons in. So hopefully I've kind of covered a bit of that about the soft tissue in the growth plates. And when we do our ACLs, even if we're not avoiding the growth plates, we try and make our tunnels quite vertical. And actually the surface area of the tunnels that we're making, particularly with the sockets that I'm doing, are less than 3 millimeters across, and actually would have not so much of an impact on the growth. But like I said, even if you're avoiding them completely, we're really very careful to follow patients up and just make sure that they don't have an issue longer term. So to prevent fear and increase post-op success, would a Wallant style procedure be possible? So that's a wide awake surgery is what I think Wallant is discussing. Interestingly, not for an ACL reconstruction, because it's too uncomfortable of a procedure to be able to do with local anaesthetic, or with the patient could be awake with a spinal, but they wouldn't have muscle control. They wouldn't be able to really interact, which is part of the sort of wide awake surgery movement. What we are doing, and again that comes back to that incredible technology, the Arthrex nanoscope, which is about the size of a white needle. There's a move that I'm in the process of trying to work out a way of doing this in a very safe manner, and we're trialing it in theatre at the moment, is to be able to do an arthroscopy and potential meniscal surgery with somebody awake, just with some simple local anaesthetic. At the moment, we want the backup of an anaesthetist, so you'll be in theatre, but the aim longer term is hopefully to try and be able to do that, explain to the patient what's going on, let them see what's happening with them awake, and pain-free to be able to deal with their meniscal tear. The other one is from Rob. Return to sport. ACL protocol is dependent on objective measures, not post-op time. So you're just reiterating exactly what I was saying, which is absolutely fantastic, that really what we're looking for is when patients are functionally able to do what they need to do to be safe in that sport, and that their physiology matches up with that. So yeah, no, absolutely. I think this it's in the press. It's propagated by injuries in football, where there's this race to get people back to sport, and actually, it isn't for the benefit of the patients. This is the benefit of the football teams who are making lots of money out of these players, and long term it does them harm. So yeah, absolutely, do not rush anybody back to sport, and if anything, longer and more rehab never hurt anybody. So I hope, if everybody doesn't mind, I'm going to just move through into the next section, which is the other thing that I do a lot of, which is the patellar instability side of the pediatric patients. That's the thing that takes up the majority of my time, and is something that's really not dealt with in a lot of places, and it takes a lot of hard work in order to really deal with these patients properly. So, taking second case, we call this patient Lottie, who's 16, patellar instability, fit and healthy, slipped on the stairs at home, a minor twist, felt severe pain, her knee gave way, unable to bend her knee, and was kind of stuck on the floor, noticed it was deformed, and could see that something was out of place. She tried to bend her knee, pushed her hand on it, suddenly went back, something clunked into position, swollen and painful for a couple of weeks, and kind of returned to normal day-to-day activities. What you do with that person is, oh, here we go. So this isn't the first time this has happened to Lottie, okay? And this is the common story. This is something that will often have always been there. They've always had a problem with their knees. They've just never really necessarily been able to kind of really understand or put a label on why their knees are not right. It's often a family history of things. Been avoiding most exercise and activities now. She really can't trust her knee. She's seen by physio multiple times in the past because she's been seen in a fracture clinic with somebody who doesn't really understand. They know that they've dislocated their patella. They do an x-ray, it looks normal, and are sent away. She's now getting really disillusioned, really unhappy, starting to end up in this scenario almost with chronic pain, really fatigued easily with their knee. And interestingly, both her mum and her aunt had very similar problems. As mentioned, seen by orthopedics before discharge, and turns up on GP's doorstep, really not being able to cope. What do you do next? So send them to me is the bottom line. And almost no matter where you are in the South Coast, there's a couple of people that are interested. I'm quite happy to take anybody from anywhere, and we take quite a lot of tertiary referrals from all over the place on the South Coast. It's a really, really complicated problem. Needs referral early. If it's an acute first-time injury, an x-ray, because when your kneecap dislocates and when it goes back in, it will often hit the side of your trochlea and it can knock a great big chunk of cartilage off. And if there's a tiny flake of bone seen on an x-ray, like I'd mentioned before, that often has an absolutely giant piece of cartilage that's really important for that knee attached to it. So it's something that may need surgery. MRI, again, is the key thing for giving us more information. And if you can get one done beforehand, absolutely ideal. If you can't, then that's not a problem, but a really quick referral is very relevant. Lots of different reasons for why you can have patellar instability. You've got two real distinct categories. You've got one who has a normal knee, who's sustained trauma and it's been forced out, and it's really just a case of things have been stretched. The more complex ones are the ones that have all of these problems. So hypermobility, really elastic collagen. There's increasing number of patients being diagnosed with Ehlers-Danlos type syndromes. It's been much more aware to GPs and physios and everybody else about this kind of laxity of collagen. A family history is almost always there in children that have hypermobility and dislocating kneecaps. It's a congenital deformity. They have a trochlear dysplasia, so they don't have a groove that the kneecap can track in properly. And if they've had chronic dislocations, actually, the trochlea needs your kneecap in there to form a groove. So if the kneecap has never really been in the groove for a long time, then you're not going to have a trochlea there. They're often patella alta, so they've got very high riding kneecaps, which means that it doesn't engage early when they're bending, and it gives it more likelihood of it dislocating laterally. They often will have femoral malrotation. So what you typically see is somebody who's kind of in-toed, patellas are pointing at each other, valgus knees. All of these things are increasing their Q angle, which is the angle between their quads, their kneecap, and where it attaches onto the front of their tibia. And it means that when the quads are pulling, you've got this lateral force trying to pull your kneecap out of a groove that doesn't exist. So there's lots of different things that you need to do to try and fix that. So the problem has come that the MPFL ligament reconstruction became really, really popular, and that's because it was a relatively straightforward operation. Before that, there wasn't really anything some orthopedic surgeons could do to help these patients. So as soon as this operation became available, and it was quite easy, that everybody that came in with dislocating kneecaps just got an MPFL. And clearly that's not going to work because there's so many other things that are potentially wrong with their knees. So you need a full toolbox. So the things that I do on a regular basis are tibial tuberosity osteotomies. So that's taking the attachment of the kneecap, of the patellar tendon where it attaches onto the tibia, and moving it so that your kneecap can run in a more normal fashion, reducing your Q angle. Reconstructing the medial patellofemoral ligament is really important, and if you think about that, is like a safety rope on the inside aspect of the knee. So it attaches it's the medial side, it's the patella to the femur, and you have a ligament there, and your kneecap should be able to move over to the lateral side and allow some movement, but it can't go right over the edge of the lateral edge of the trochlea and actually dislocate. So it's a bit like a climber going up a mountain where they will fall, but then the rope catches them before they hit the ground. So that's what your medial patellofemoral ligament does, and it's really very important. The other one is changing all the other things that are potentially wrong with the patient. So if they have internal rotation of their femurs, if they have a valgus deformity, then we want to be able to straighten their legs up, derotate them back out to where they should be. And the other one is giving them a groove that their kneecap can actually run in. So that's called a trochleoplasty. So I think I've got some pictures here. So this is a patient that we operated on. She was 16, and she had, you can see the internal rotation of both of her femurs. Her kneecaps are sitting probably where they should be, but her femur has been moved out the way from underneath. So there's no way that that patella can track where it should be. There's no groove at all. It's actually a dome. And if you look in the other picture, I've kind of drawn a line where that is, and trying to have your kneecap run in that groove is impossible. It's like balancing two balls on top of each other. So even this person had a medial patellofemoral ligament reconstruction without addressing any of the other things. So they hadn't changed the rotation, they hadn't changed the trochlear groove, they hadn't changed the attachment of her patella onto the front of her tibia. So there was just no chance that that patellofemoral ligament was ever going to really work. So for instance, in this patient, we had to do an osteotomy to get rid of the valgus deformity, derotate her femur. We did a tuberosity osteotomy, and you can see with the two screws. The two holes in the patella are where we attach the ligament for the medial patellofemoral ligament reconstruction. And we can use either synthetic with the fiber tape, or we use hamstrings again. So that was before, and that's after our trochleoplasty. So if you can ignore the box of B&Q screws that have fallen on her knee otherwise from the other surgeries that we've done, if you focus on the groove underneath the patella, you can see the massive difference that that trochleoplasty has made to that domed trochlea, and you can only imagine that that's going to make restraining her patella so much easier in the long term. So finally, just a very quick mention, anterior knee pain in kids is pretty common. It's very rarely that it's got no cause at all. It's just often that you haven't really found what it is yet. Chronic pain is difficult to fix, even if the problem is fixed. So if that person's had that pain or that problem for a very, very long time, that's where we get into real problems. You know, when I see somebody who's 30, who's had maltracking patella for all that time. Even if we fix their tracking problem, getting rid of that pain is incredibly difficult because they've lived with it for 15, 20 years. Trying to address the expectations of the patient and really giving them exactly what they want is often very difficult. Chondromalacia, subtle tracking problems of their knee, often don't warrant a trochleoplasty or a major bony operation, and it can be very difficult and a very difficult conversation with somebody to basically say that they're going to potentially have to change some of the activities that they do and modify their lives around about their knees. Some things we can't see on an MRI scan or on an X-ray, and in the general we have what's called SPECT CT, which is a combination of a CT scan in 3 dimensions and also a bone scan. So rather than just looking at the physical manifestation of cartilage damage, what we can see is actually inflammation and bone turnover. So we can see where there's been excess pressure on the joint, and that gives us some ability to understand what it is that's driving the problem for the patient, and therefore if we do an offloading type osteotomy to help take some of the pressure off their patella tracking, gets rid of some of their pain. So it just shows that it's about finding that out, and just because somebody doesn't have something that we can identify or test for doesn't mean that they don't have anything wrong. And some of these conversations that we have in clinic are incredibly long for patellofemoral stuff. So that's just going through Lottie's. MR is important, and it's basically going through the same things that we've had. What I would point out of this is injections, and in kids that's a difficult one. I would tend to stay away from steroid type injections. I certainly would never do a steroid injection in a child without having imaged them first. There are other things that you could potentially do, such as hyaluronic acid type injections. I think where injections are useful and where patients don't necessarily understand is that it's not just numbing the pain for 3 months to then be back at square one. My aim of giving injections is to get them some respite from the pain that they have, to allow them to then use and move their leg more normally, because they'll have ignored their quads. They won't have the bulk, they won't have the symmetry that they should have, and that respite from the pain just gives them an opportunity to get back to where they were before. So that's my reasoning for injections, not just as a temporary fix for their pain. So I hope that's not been too detailed. I hope that's kind of focused on some of the things that people wanted to know and what was being asked. If it's not, please feel free to email me. My email addresses are up there. You guys have all had my website address. There's a contact form on there. There's referral forms on there. So, some of the questions before, I think it was Joe Pont and Rob, if you're really struggling to get where you want to be or have a patient referred, fill in that referral form. It doesn't matter if they're NHS or private. If they're not a private patient, I can still try and engineer getting them into the acute system more quickly. So anything anybody wants to know, don't hesitate to contact me directly, and that would be fab. All right. So I think that the technology has worked. I think I've seen this working on YouTube. So this is now recorded. If you've not managed to stay for the entire thing, or you skip through all the boring bits, or there's a bit that you want to look at again, if you go back to the YouTube channel, probably in another couple of hours, this video will be on there for you to be able to view again. Hopefully we'll do the same sort of thing again, and I really appreciate everybody's questions. Well, there's just one more. It says, Louise Fox, is there a cutoff depth of trochlear groove before you would consider surgery? So the trochlear groove, there's a classification for trochlear dysplasia, which is the de jure classification, which is the chap I went to see in France. If you Google that, there's basically 4, which is one more than normal orthopedics, but that shows you the different shapes of the trochlea, and it's the de jure D is really the one. So it's a significant operation, and it's not one that's done lightly for some subtle changes, but in a sense, the cutoff is not really relevant from elsewhere. It's something that is pieced together with all the other problems that the patient has. So it really tends to be when they're very severe, and you definitely can't do it when they're older and they have degenerate change or arthritis. So that's why it's really, really important to do it when it's younger. The only caveat I would have with that is in the pediatric population, you cannot do a trochleoplasty with open physes. It's not something that is like an ACL where you're drilling a small tunnel. This is an extensive operation that would have significant damage to the physis. So that is one of the few things that I would wait until they've stopped growing before carrying out a trochleoplasty. And because you need to do other procedures with it, I would tend to delay their entire surgery and do it all properly at once rather than try and do it piecemeal or to take a chance. I'll just have a quick look if there's anything else. Do you involve psychology for your more chronic knee patients? Not formal psychology. I must admit that in clinic, sometimes on a Wednesday, when I've spent 40 minutes chatting to some patients, I do try and go through the psychology and really, really talk in detail with them and try and understand where they're at. And that's all part and parcel of that kind of complex tertiary referral practice. So it's not formal. I don't call myself a psychologist, but I feel like at the end of a day, I've done quite a lot of psychology with patients, and I think that really pays off actually in their expectations and what they get out of the surgery. Yeah, clearly, if somebody is really kind of troubled with something and it's a real problem, then absolutely I refer on. But I haven't been in that position to do that yet. So I don't see any more questions. There's kind of a couple of minutes left for anybody that wants to ask any more questions. I'm glad. I hope that's been useful for everybody. I'll give you guys a little bit. Esther Buller, thank you so much. That's helpful. Good. I'm glad. I'm just more terrified about the technology. I thought I'd take a chance and try and do something a bit different. It worked, I think. Apart from the fact that my heart rate's about 200 because I was worried that YouTube wouldn't work, but there you go. Okie dokes, so I've probably taken way more of your time than necessary. Like I said, you can always watch this back and I'm always available, so give me a quick email or a text or put a comment underneath this and I'll do my best to answer any questions that you guys